how did the healthcare industry in the United States become what it is today? The debate on how to properly run our healthcare system spans back to the early 1900s, but one act has pushed this complex issue to the forefront in a way we never saw coming.
This is an event and images that have shaken the city to its core.
An early morning assassination.
You wonder how this could have happened.
We're asking every New Yorker and American to assist us.
On December 4th, 2024, at 6:44 a.m., UnitedHealthcare CEO Brian Thompson was shot from behind as he walked down West 54th Street in Midtown Manhattan. The firearm used was a 3D printed Glock 19, and the words delay, deny, and depose were inscribed on the cartridge cases left at the scene.
There's some sort of a personal or ideological motive around this specific target.
Unfortunately, Thompson was pronounced dead less than 30 minutes later at Mount Sinai West Hospital. While police and the FBI searched for the perpetrator over the course of the next 5 days, the case took the internet by storm. But unlike most high-profile murder cases, the identity of the killer took a backseat to a larger conversation about healthcare, conflict, and greed.
People have become increasingly frustrated with private insurance.
On December 9th, 2024, the suspect was revealed to the public to be Luigi Mangione.
We got Luigi!
Some people seem to admire him, like him.
If anything good is going to come of this, it's going to be policy change.
Health over wealth!
Mangione was recognized by many as a hero fighting against a broken system that has failed countless people. With UnitedHealthcare reporting $22 billion in profits in 2023, many normal, law-abiding citizens are feeling this act of vigilantism was not only justified, but righteous. By the end of 2024, Christian crowdfunding platform GiveSendGo had raised more than $200,000 for Mangione's legal defense. So what led us to this point where our relationship with our own healthcare system has become so volatile? How do doctors and providers like us feel about the current state of this system? And most importantly, how do you as a patient feel about it?
So let's start by kind of touching on the history of the healthcare system.
You know, I love talking about the history of healthcare or the history of medicine in general.
Yeah.
Like, I have a favorite story about the history of healthcare. Do you have one?
I don't.
You don't have
I don't have a favorite, no.
So, like, here's the thing, is one of the coolest stories for me,
Yeah.
right, is a story that happened almost, 300, 400 years ago. So it was like in the 1700s.
Okay.
So in the early 1700s, right, smallpox was like ravaging through the United States, right? Smallpox, the virus that can kill people. So smallpox was ravaging through the United States. And in Boston, again, slavery was big then, right? And so at that particular point in time, there was a slave owner by the name of, I wrote his name down. His name was Cotton Mather. He was an enslaver, all right? Now, smallpox was ravaging through, and one of his slaves, whose name is Onesimus, right, obviously from Africa, had mentioned to him, said, hey, listen, like in Africa, this is what we do to handle smallpox. And he was like, well, what do you do? So the pustules that develop in people when you have smallpox,
right?
We take that pustule, we pop it, we take the material that's inside, and we put it in an open wound in another person. And what we noticed was most of those people didn't get as sick, right, with smallpox. And it was almost like the beginning of really understanding immunology and vaccination, which is really cool. Which is why I love the story.
Yeah.
So this slave owner ended up partnering with a physician, Dr. Boylston.
Okay.
And he was like, hey, listen, man, like, why don't we do this? Why don't we inoculate people with smallpox doing it this way?
Yeah.
And see if
we can control this.
We can control it. And if the mortality is less. Because at the time, mortality for smallpox was like 14%. Like 14 out of 100 people were dying from smallpox. So they did this. And they actually studied this. And there's like numbers. So they actually inoculated 282 patients.
And this is in the 1700s.
This is in the 1700s.
Okay.
And 6 patients actually died of smallpox, like 2%.
Right.
But again, as I said earlier, the mortality of smallpox at the time was 14%.
Right.
So this kind of initiated almost this thought process of medicine, which I think is very important historically. And
Sure.
honestly, Dr. Boylston gets all the credit, but it was really Wanzamis whose idea it actually was.
Oh, yeah, he deserves the
Which was-
credit. Yeah.
which was common practice in
Yeah.
Africa and Asia. So that's kind of like one of the coolest stories that I think about in healthcare. And it kind of like when I read about that years ago, I was like, man, this is like science at its best. This is really cool.
Yeah.
Like this is the beginning of understanding. But when you look, at the history of healthcare overall, especially in the United States, everyone across the world, they were all trying to do the same thing virtually at the same time.
Yes.
Which was develop this like national healthcare system, because most countries in this world believe that that is absolutely necessary for the country to be able to provide healthcare for everybody.
And now you're kind of going into World War II, I'm assuming. That's when we really start.
In the early 1900s,
Yeah.
is, when the country is kind of getting more and more organized. Right?
Right.
The American Medical Association started in 1849, but in the early 1900s, there was heavy work in industrial regions of the country. And it was heavy machines. So people were getting injured. People were getting hurt. And when they got hurt and they couldn't work, they couldn't make any money.
Correct.
They couldn't provide for their family. So this is kind of like when sickness funds started, right? And this is what it was like, okay, well, we got to provide money for individuals that get hurt on the job.
Yeah.
So that way they can continue to support their families. And there was actually the American Association of Labor legislation around 1906. They're kind of the first group that started targeting this working class. They started targeting kids because if people couldn't work, they couldn't make any money. And if they couldn't work because of injury, they felt like it was the employer's responsibility to be able to provide that.
Yeah.
So
this is the beginning of employers providing insurance.
Exactly.
Yeah.
For people that worked for them. And so what they did was they kind of split the cost between like state and employer and patient is what they really tried to do. And at first, the American Medical Association supported this.
Right. Yeah.
They were like, yes.
The thought was there. It made sense.
Yes, we absolutely feel this way. We want to support you. Insurance companies, private insurance companies started to develop around this time as well. And over the course of time, that bill, those thoughts, the American Medical Association kind of pulled out. And they were like, no, we don't support this anymore because people were worried about physician reimbursement and what the physicians would be able to obtain from these things. Fast forward about 20 years or so. In Texas, at Baylor, there was a group of teachers that needed care. Hospitals at that time weren't making very much money, right? They weren't full. So hospitals said, hey, listen to these group of teachers. We'll charge you like 50 cents a month, and we're going to let you be able to be admitted to the hospital if you get sick.
Yeah.
Right? And what they felt at the time was these teachers were pretty healthy. They're a pretty healthy group of people.
Well, yeah.
Yeah.
They're looking at the demographic and they're saying, here's a group that's young. What are the chances that they're actually going to get really sick?
Right.
Right.
Exactly. It's exactly
risk
right.
pooling.
Right.
Yeah.
And so 50 cents, and 50 cents at the time is equated to about $9 now, by the way, just so people know. So they would pay 50 cents a month. They got this healthcare. So eventually, that group that developed that process, that evolved into what's known as Blue Cross.
Yeah.
So physicians were like, well, wait a second. The hospitals are getting paid, right? What are we going to get out of this?
What are we going to get paid? Right.
So physicians ended up starting something to offer kind of outpatient services, surgical services, and hospital services as well, and some that partnered with hospitals. And they called this Blue Shield.
Yeah.
And so this is when, the beginning of health insurance, as we know it today,
Correct.
sort of began. But throughout this entire process, physicians were worried about discriminating fees. They wanted to be able to set their own fee. They wanted to be able to set the fee to provide for their family or make money or however you want to look at it, right? So physicians always felt some type of way about this practice, right?
Yeah.
Because you had these insurance companies, right? These early insurance companies almost beginning to set the price and set the cost for healthcare. And physicians started to see that.
Where do we fit in here?
Exactly.
Yeah.
Exactly. That's exactly right. So this is kind of like the beginning of the insurance industry. right? Now, what was going on in the rest of the world was very similar, except in the rest of the world, what they decided was that they could have these funds, but they wanted to have control over these funds making a certain amount of cash flow or a certain amount of money, right? Now you hear about all of these.
It became a business strategy.
It became a huge business strategy. Right? It became a huge business strategy.
So that all started around World War II, right?
Yeah. So at the time of World War II, to basically protect against the cost of like wartime inflation,
right?
The government essentially said, listen, you guys, the companies can't increase their wages. They can't increase how much they were paying people. So what that ended up doing was it led to employers offering insurance plans and
that was
health
the beginning.
Insurance plans, right? That was the beginning of it. So the employers would say, okay, well, I can't pay Bill more money. I'm going to give you this health insurance that's going to cover XYZ. It'll cover your family. And that's kind of how this competition of insurance companies like began.
Yeah.
Insurance began to evolve, and this is where, you know, the employer and the patient splitting the costs of insurance started.
Yeah.
What also started around this time was on the West Coast in California, I think like near Oakland. That's where there was a huge shipyard, and there was this gentleman by the name of, was it Henry Kaiser?
Okay.
So Henry Kaiser said, and he partnered with a physician. He said, hey, listen, I want to pay for all these workers to have health insurance because they would get sick, right? They would get pneumoconiosis, which is, you know, inhaling a substance and causing inflammation of your lung and scarring of your lung.
Right.
And he wanted to make sure that these patients had care. So what he did was he partnered with a physician and he said, hey, listen, like, we're going to pay you this amount of money. You can have all of these patients to take care of. And that's how Kaiser started, right? Was like that.
Yeah.
This was kind of the first organization of healthcare that we call a health maintenance organization or an HMO.
Right.
Right. So whenever patients are signing up for health insurance, one of the first questions we ask is, do you have an HMO or PPO?
Or PPO.
We just got in that discussion a few moments ago.
Yeah, we did.
Right? Because, again, my co-host here, you don't care if I tell him that you have asthma. Do you care?
No, go ahead, please.
So co-host here has asthma and is not treated very well.
It's not.
And so I said, hey, I'm just going to call in a prescription right now. I'll call it in. I'll have the pharmacy just deliver it here so you can have your inhaler because you've been coughing all morning. Right?
Yes.
But turns out she has an HMO. So I can't just call any random place for her to get her prescription.
Yeah.
I have to get it from her particular place that's an HMO. So that's what an HMO is, right? So an HMO is an organization that provides care. You're prepaying care, but there's a certain network of physicians that can see you. And then there's also a certain pharmacy that can give you drugs, right, as well, drugs that are needed.
Yeah, specific pharmacy.
Right. And so if you want to go outside of that, you just have to pay cash. Like they don't pay for anything outside of their own thing.
Exactly.
And there's a certain formulary they have, and there's certain rules and regulations. HMOs are typically speaking a little bit cheaper when compared to PPOs, which are more kind of patient-centered, so patients can kind of go anywhere that they want to go. The PPO will pay for some of it.
Yeah.
Those premiums, and by premiums, I mean the amount of money that you're paying every month are a little bit higher, right? So those premiums, and I think I wrote it down, the average annual premium for a PPO is $8,900. The average annual premium for an HMO is like $8,200. So you just divide that by 12 to get the monthly fee, which is kind of expensive. I mean, it is expensive.
Yeah.
But with a PPO, which stands for a patient provider organization, a PPO, they have networks of physicians as well. You can go to those networks of physicians, but there's also some out-of-network funding that you can get if you want to go see a different kind of physician.
And even you just explaining this, it gets so messy.
Yeah.
Right?
It can.
It's not straightforward, in my opinion. I mean, I have this discussion with my patients all the time.
Yeah.
And they're like, what avenue do I even go down? How do I know which avenue to go down?
Yeah, and it's such an interesting question because for me, and again, we're talking about individuals that have health insurance. The way that I answer that question for my patients is I will say, all right, well, let's look at your specific plan and see what your plan actually covers. And I think understanding what your plan covers comes with understanding what medical history you have.
Yes.
Right? So what medical history do you have? and what medications do you need? Because whatever plan that you have or that you select, you want to make sure that it covers what it is that you have, and then even your family, right? What does your family have? Now, the numbers I just quoted about HMO and PPO price, that's for like one person.
Right.
If you're including like family,
which most people are,
it goes up significantly. It's like $24,000.
Yeah.
Right. So like for an HMO, it's $24,000 for a family. For a PPO, it's like $25,300.
I don't think there's a lot of physicians out there, providers out there that are doing what you're doing, though. You know, I think a lot of patients do come to their provider hoping to get some sort of guidance, right? And you have your patient come in and you're like, we're talking about your heart or your lungs today. We're not talking about what insurance you should pick.
Right. And again,
so then they're kind of like lost again, right?
And again, this goes along with your staff. So it takes time, right? So I have the office manager in my practice. And my practice is I share an office with 3 primary care providers, a father and 2 sons. The father's been practicing medicine for like 65 years. And he's had the same office manager for probably 40 years. So this person is the most valuable person in our practice because she knows all the insurance plans, backwards, forwards, what they cover. She is like the god of health insurance and like understands. Like,
well, you're blessed.
I'm completely blessed.
Every office needs that, but I wouldn't say every office has that person, unfortunately.
No, because this isn't something that we're exactly taught.
And we're not.
Yeah, as we go through healthcare, as we go through all of our training.
I think that's a really good point to the public as well, is that even as providers, there's a lot that we don't know about the healthcare system, how things are paid, where the money's coming from, so on and so forth. We do our best to educate ourselves,
right?
But there's an opaqueness to it all that makes it a bit challenging.
Yeah, and I think most people have to understand that having a job, right, and having an employer, that's generally speaking how like 65% of people in this country get their health insurance.
Right.
They have an employer and the cost is split between patient, employer, right? Period. End of story. That's how it goes, right? The other thing about healthcare, we know the United States system isn't the greatest because it's not one system, right?
Yeah.
There are essentially 4 different systems when you look around the world. And I think we have to make certain that we understand each system and how it works, right? When you look at the United States, you've got elements of all 4 of these systems, right? Which is what makes this super complicated. And there's other things that go along with it that make it complicated that we're going to discuss. But let's first get into the 4 different systems that we have across this country. And so, again,
and you're saying that these are systems that other countries are utilizing, but in the United States, we seem to kind of try to utilize them all, for better or worse.
We do utilize them all.
Yeah.
Right. So what I'm saying is, when you look around the world, and you look at Europe, if you look at England, and some other rich countries around the world, they usually abide by one of these 4 systems.
Right.
Period. The United States uses all 4 systems in one country, which is what makes this really confusing.
Yes,
right?
yes.
So the first system I'm just going to discuss, and I'm going to just give you a brief discussion of this history, is the Bismarck system. So the Bismarck system is, like I mentioned earlier, it's an employer payment model, right? Again, 65% of the people in this country have that model. So basically what happens is you have health providers and payers, which are private, and then you have an insurance company, right? So the insurance company is going to pay for your health care via a premium that you pay every single month, right? Here's the kicker about the Bismarck system. In every other country except the United States, the insurance company or the sickness fund does not make a profit. The United States is the only country, only rich country, in which these sickness funds or these insurance companies make a profit. Money. That's a big difference here that we have to discuss, right? So I also want you guys to know, Germany does it, Japan uses Bismarck, France uses Bismarck, Belgium, I was in Belgium recently, and Switzerland, right? They all use this Bismarck system. Then there's the beverage system. Now, the beverage system is used in England. In other words, the government provides all the healthcare. They own all the hospitals, they own all the providers, they pay the providers, they pay for the patient's healthcare. And the way that they pay for this, because they're the sole provider of healthcare across England, is they tax the shit out of you. So like whenever you go to England, I don't know if you've been to England before.
Yeah.
It's expensive as hell.
It's very expensive.
And the reason it's so expensive is because they have a 20% like sales tax. And that's to provide care for their country. They decided
this is how we want to do it.
This is how we want to do it. This is how we're going to pay for it. Now, we see evidence of the beverage system in the United States at the VA. When you look at the VA, the patient doesn't get a bill. Everything's paid for by the government.
Right.
Period, end of story. Surgeries, prescription medications, all of it. So there's evidence of the beverage system here. We talk about evidence of the Bismarck system because that's how 65% of the people get their health insurance. And then there's the national health insurance model, which Canada does. Now, in the national health insurance model, the providers may be private, but the payer is the government. So the government is paying essentially every single physician in Canada.
And people, just to touch on this as well, people tend to favor Canada's healthcare system. But I just want to preface that because I know people's heads are going, oh, Canada, we like it. We like Canada's. Keep going on this because I think that there is pros and cons to all of them.
So the con that you're actually alluding to is the long wait times, right? And so these patients have long wait times to get seen. Now they're doing something to shorten those wait times.
They are.
I'm not going to sit here and say that like if you live in Canada, it's going to take you forever to see a doc. But they want it to be equal for everybody, whether you're rich or poor, you know, black or white, doesn't matter. They want it to be equal.
The wait times are equal.
So the wait times are equal across the board. I got a lot of patients that get their prescription drugs from Canada.
Oh, I do as well.
Right?
Yeah.
Because they're significantly cheaper.
I tell them how expensive they are in clinic and they're like, we'll be back.
Right. Because when you're the government, you're just setting the price. You're like,
Right.
hey, like, this is what we're going to pay.
Yes.
Period. End of story.
Yeah.
Sorry, XYZ company, this is what we're paying. Like, it's the way it is, right? 'Cause
Yeah.
that's how other European countries and other rich countries, including Japan, that's how they do it, you know, around the world. So this national health insurance policy or national health insurance plan, right, is really run by Canada, in which the government pays the physician. And then you just have out-of-pocket costs, right? Out-of-pocket, period. That's fee for service.
Right.
You see somebody somewhere, and then you pay cash for their services. Now, if you think about the United States, we have all these systems.
We do.
There are physicians that only see people cash, and you got to pay cash to see the physician.
Yeah.
We talked about Bismarck. We talked about the beverage and the national insurance model. Where do we see that in the United States most commonly? Well, that's Medicare. Anybody 65 and up, the government's paying for it. In fact, when you look at healthcare plans, the way that I'm reimbursed, sometimes like UnitedHealthcare or Cigna will say, well, I'm going to pay you 80% of what Medicare pays you.
Right.
Medicare determines the cost, or the United States determines the cost based on something called an RVU, and then there's a conversion factor, and the conversion factor is a dollar amount. So the conversion factor right now is like $32 or something like that. Say I'm doing a procedure. There's a procedure I do called endobronchial ultrasound with lymph node biopsy. It's worth about 4.5 RVUs. So you multiply 4.5 RVUs times 32, and that's the reimbursement that I would expect for that particular portion of the procedure that I'm doing.
You're talking about RVUs and you know the numbers, so you know what they're charging, right? Mm-hmm. Do you know yourself how much that procedure costs? Like the hospital, like do you as the provider know the actual numbers?
So here's the thing, is doing the procedure in a facility costs money, right?
Right.
So I think that's what you're referring to. So you have the hospital charge. So the hospital is going to charge you for using their facility. The hospital is going to charge you if you use an anesthesiologist.
Right.
The hospital is going to charge you for the equipment that was used. You usually get an IV. You got to put in a vein here. So the IV goes in the vein, right? So the nursing that's responsible for taking care of the patient at the bedside during the procedure. You're paying for all of these things in one lump sum, right? And so it depends on the hospital's charge, or it depends on what the insurance plan has negotiated with the local facilities.
The word negotiated, I think, is my point here.
Yeah.
So there's this bigger number that I feel, again, is kind of elusive. It's a little opaque. Mm-hmm. And somehow, though, most of us don't know, even the providers, that number. Yet we put in a 5-digit number that says, well, this is what that cost is. Mm-hmm. Do we know that that is actually what that cost is?
I mean, again, that's we don't. Like, that's a value thing, right? So the hospital buys all the equipment.
Right.
The hospital has the space. The hospital hires the staff. The hospital is responsible for coordinating all of the care. So they want to get reimbursed. And most hospitals, I don't even know if it's most really,
Yeah.
but hospitals are for-profit institutions. They want to make money. So of course they're going to charge what they think it's worth.
So if we as providers don't even fully comprehend the cost of even the procedure you're referring to, think about the patient who's walking in, they've signed a consent to have a procedure that they think has to be done, right? And they have no idea what that cost is going to be. In fact, oftentimes they don't even know what the cost is going to be for them for months until they get a bill in the mail that says, here you go.
And now what they're doing, hospitals, is, so like we had breast cancer, right? We know my wife had breast cancer. She had to have surgery. She had to have a mastectomy. So we go to the hospital. Okay, we go see the breast cancer doc. We go see the breast cancer surgeon. Clinic visits are covered. Of course, we had to pay a copay, like $20 or $40, whatever it was. But then we go to the hospital to have this surgery. As soon as I walk into the hospital, we're checking her into the hospital to have the surgery. First order of business. Oh, by the way, you have to pay this much cash. It was like $2,700 or something like that I had to pay like right away.
When you're walking into a procedure for your wife to have a mastectomy, just the emotional battle that's going on.
All of that.
And now they're saying, oh, you also owe a couple $1,000 right now.
Right now. Now, again, this is a lot of money right away. What if this was an average patient?
I was going to say, the average patient's going to look at that and potentially not be able to do it.
I mean, and this is a procedure that's completely necessary because, you know, the patient, my wife in this case, had a malignancy. And so, again, when you look across the world of healthcare, they have their prices posted on the wall. Like, they know how much it's costing, not to mention the fact that they don't have to pay for it. Right? The insurance company that, or the sickness fund or the government is paying for it. But again, there's no surprise across the world. There are surprises here all the time.
Oh, patients are literally going bankrupt, losing everything because they can't pay their insurance, or they can't go have these procedures that they have to have done.
Yeah, and it was something like, you know, a few years ago, before the Affordable Health Care Act, but a few years ago, it was something like 700,000 patients a year were filing bankruptcy because of healthcare expenses.
But as far as things go with the Luigi case and the CEO shooting, we are seeing an outpouring from social media influencers on, I'm going to say, their opinions, right? How do you feel about the way that is being driven?
I mean, one of the problems with, I guess it's this country, is it takes something so crazy, so wrong, for people to actually voice their opinions on things that it just drives me up a wall. Like, why do you have to shoot and kill somebody to really create a voice and audio on the healthcare industry? Like, I don't like, I love that it's receiving attention. I hate how the attention started.
100%. Yes. Yeah.
Like, it really bothers me that some guy who's from Ames, Iowa, doing his job,
married with two kids,
gets shot in the morning as he's walking to a meeting. Like, come on. Nobody deserves that.
No one deserves that.
Nobody deserves that. But talking about the healthcare system in general, I think it's important. I mean, we experience this every single day. Like, we see people every single day, right? We hear the stories. I mean, like, when I was a kid, my grandmother had a thyroid goiter. I've talked about this before. She had a thyroid goiter, and the thyroid goiter kept getting bigger and bigger. Now, my grandfather worked for the Air Force, and he had health insurance. Okay? Well, we were black, so we couldn't get health care in certain areas of the country. And so my grandmother could never get this taken care of, the goiter. Because doctors wouldn't see her. Goiter got bigger and bigger, needed a surgery, couldn't go to the white hospital to have the surgery. So had to find some like back alley black surgeon, do it in a place that he wasn't familiar with. And that's when her recurrent laryngeal nerve got cut.
Right.
And why she had a paralyzed vocal cord and couldn't breathe and ended up with a tracheostomy years later.
It's awful.
Listen, I know racism was alive and well, and I'm sure, and I know it's still alive and well today even, but the healthcare part of this piece, the healthcare piece of this is what bothered me the most, because it's like my grandmother couldn't get care. My grandfather was in the damn Air Force and she couldn't get care.
Yes.
And it led to all of these consequences. So now when you look at your patients that you're taking care of.
Well, we're still seeing that in clinic today. I have patients, I was just having this discussion with my team this last week. I spend almost every single one of my lunch breaks doing peer-to-peers, which essentially means that I'm trying to get authorization for my patients to have procedures that we know they need to have, whether that be an ablation, whether that be new technology for heart failure that is FDA approved that we know would benefit this patient substantially.
Yeah.
And it gets denied.
Right.
Right? And so it's coming back to me, and then I'm doing, and I don't know if patients realize this, but when it gets denied, now it's being sent to me as what we call a peer-to-peer. So I'm getting a phone call, usually on my off time, from a doctor somewhere. Usually, in fact, never have I had a provider that was within my specialty telling me why they denied it and asking me, well, tell us why we should do it. And I could lay the facts out, which I've already done. You could read my notes. I mean, I sent it, and they will continue to deny. Mm-hmm. So what most providers and patients don't realize is we have more power than we realize. When it gets denied, a lot of times we're like, well, that's it. What do we do? It was denied. I sent it was denied. Now I did a peer-to-peer, it's been denied. Game over. I guess this patient, and that is what they are counting on. Don't stop there, okay? The patient and the provider can try to go again and do another peer-to-peer. And oftentimes when you're willing to push it even that one more step, we win. We can get the procedure done. But it's awful that we have to go through that. And for a lot of providers, it's time, it's manpower. We don't have it, Yeah,
it's like 30 to 40% of claims are denied.
Yes.
Which is crazy to think about.
Which is crazy.
Like in any other country, you basically submit your claim and you're paid sometimes within 3 days, right? At least within a month in England. Like you're paid within, it's ridiculous. But here in the United States, it's not so.
It's not so. And
40
it's
to 60 days.
It's not just procedures either, right? It's medications.
Yep.
You're talking about really important medications like anticoagulants for patients who have atrial fibrillation to prevent stroke. We're talking about heart failure medications that literally could save a patient's life. Mm-hmm. And we can't get our patients on those medications. It doesn't matter what we're saying as the provider, how we're, sending it off to insurance, it doesn't matter. It's getting declined.
And again, we're spending administrative time doing this. This is not taking care of people, right? This is not like I'm seeing this person and
we're doing it there. No, we're seeing 30, 40 patients a day in clinic. And then in between, if you even say it's my lunch break, it's my morning before I get to work, and it's the evenings, the hours that I'm staying after to try to address this for my patients.
So again, there's aspects of the healthcare system that I like. There's aspects of the healthcare system that I fucking hate. Like, this is one of the things that I hate.
Same.
When I see an asthma patient right here and they don't have their medications, their maintenance therapies or their acute therapies just because of insurance, it's a problem. It's a huge problem, right? It is. It costs a lot of time. It costs a lot of money. In fact, one of the things that these insurance companies have done is they've actually written into law that 20% of the healthcare dollars can be due to administration costs.
Yeah.
So like if you're spending $10,000, right, $2,000 is administration costs, which is crazy to me.
It's insane.
It's just, I don't know exactly what to do, but when you look around the world, there are some things that are being done. Number one is their country believes that everybody should have healthcare. Cool. I don't know if our country believes that, but whatever, right? Number two is I got to be honest here. Physicians make a lot less money in other parts of the world. We make a lot less money. Now, with that being said, we also pay less for education, right? They're not paying for college. They're not paying for medical school.
Right.
All that stuff is rolled into so, and there's different ways that they get into medical school there. Like in some countries, you just take a test, and if you get a certain score, you can be a doctor. If you don't get that score, you can't be. So it's a little bit different. Like in America, if you're working hard and whatever, you can kind of get there as long as you're persistent to a certain extent. So I recognize the differences in the countries in terms of that, but at the same time, the way that they operate their healthcare system allows all of these individuals in their country to be covered. In America, the reform is going to have to include probably me taking less. I mean, we make 4 times as much as they make in England.
But to your point on that as well, doctors are making less now than they were even back in the 80s when you actually look at it. Mm-hmm. So you might make more money compared to other countries, and you made a good point there. But if we're looking at the United States, you guys are making less money than you were previously. So do you cut it back more? I mean, you guys are working harder. We just got done saying you're seeing 30 to 40 patients, mm-hmm. and you're working on all of this off time. You don't know what the answer is there.
Yeah, I don't know what the answer is exactly either. But if I'm being fair, and I consider myself fair,
yeah,
and if I'm going to compare myself to other countries, I have to look at what they're doing. I can't just say, all right, I'm going to do everything but X, right? Because that's essentially what the AMA did throughout the history of health insurance, is they basically opposed any national healthcare system because they were worried about physicians and reimbursement, which I understand. Mm-hmm. But I do think that we also have to look at pharmaceutical companies. We have to look at not just pharmaceutical companies, but insurance companies and something called pharmacy benefit managers, because there are all these companies that are associated with healthcare that are now taking a significant profit.
Yeah.
Right? So they take this significant profit of money, and that money is away from the healthcare system and going into somebody's pocket. Right?
There's a lot of levels to this.
Yeah.
And we could dive into a level per pod mm-hmm. and be here for a year. There's a lot.
When I look at other countries, I mean, the other main thing I see over there is that the companies that are providing the care mm-hmm. are not making a profit. They're not making a profit.
Right.
Again, I'm not saying that the insurance companies, the pharmacy benefit managers, everybody that's providing care should make a profit. I'm not saying that we should make a profit. I'm just saying that when you have an insurance company that makes $100 billion.
It's just been manipulated at this point.
Right. And they deny 40% of the claims. Come on. That's a little ridiculous. So I don't know if you can put a cap on profit. I don't know if you can put a cap on what's being denied. I don't know if you have a government team of clinicians mm-hmm. who are actually responsible for saying whether or not a certain claim can be denied or not, right?
Right.
I don't know what you do, but I do think that it takes discussion.
That's the point here. We need to start discussing. We need to open up the conversation more. It's not about this murder and Luigi and what he mm-hmm. did. That's wrong.
Right.
But the conversation now needs to turn toward, what can we do? We're all in this together. We all feel the same way, or at least most of us do, whether it's a patient or a provider. How do we make progress? There has to be progress.
As a provider, there are times when I feel completely helpless because I feel like I need to know the healthcare policy. I need to know the insurance mm-hmm. plans, what they're compensating. I need to know what the insurance plans are going to pay for. I need to know that better for my patients. I need to make certain that the way that I practice medicine allows my patients to get the best care. And in doing so, that means I got to have a better understanding. That's why I love the fact that Terry can teach me most of these things. But I hate the fact that some of the best medicines out there, I can't get approved for my patients. And there are certain things I got to do to make certain that my patients do get care. I can't tell you how many times I've been like, you know what? Go to the hospital. I'll do it there.
Well,
right?
And to that point, too, we say that I as the provider, but it's also I as the patient.
Yeah.
I, as a mom, right? I mean, that makes me emotional. We're not just providers. We're patients.
Yeah.
We're family members.
Yeah.
We're trying to take care of our children and get them the best insurance and care. And it feels hard to do it.
It does. And, you know, I have friends, and a couple of friends of mine, they have a couple of kids. One of their kids had a cough recently. And their kid has a cough. Their kid's got a cough. The kid's been sick. He's been to multiple physicians. He's been to the ER a couple of times. And the right thing hasn't been completely done, right? It's always this partialized care because of the system in which we live. When you go to the ER wants to do acute medicine. Like, what's the problem? Why is the patient here? Is the patient here for this? Let me just get them out, right?
Yeah,
Because they're here just for this. Get them out if they have other issues.
Right.
But I get a phone call on New Year's Eve at like 7 o'clock because the patient's still coughing and the patient has an issue. I give the appropriate care. Literally, it takes me 30 seconds to give the appropriate care. The patient's able to get the medicine, and the patient stops coughing almost immediately. So when it's done right, and it can be done right in this country, in that situation, when it's done right, it's done well. But a lot of the times, we're not able to do it right because these fuckers say you can't do this, or this isn't indicated, or you got to write this note, or you got to put this in that note, or you need to try this first that you know is going to fail because you've tried it a million times.
Yeah.
And it's frustrating when you're getting that instruction from somebody that didn't go to medical school.
You can't be the provider. You can't just be the doctor. You can't do what you went to school to do, which is take care of patients.
Yeah.
Because you're trying to answer to all of these other people who have no medical knowledge whatsoever. I think patients don't realize that. They think that we are the answer, you know, that when we say you can't have this, or, you know, we can't get you this medication, that it's coming from us.
Right.
And it's not. So often not. It's this upper level, right?
It's not. You've got a third party in between.
Yes.
Right? People say the biggest complaint is they don't want the government to get in the way of their healthcare, right? But instead, they have these insurance companies in the way of this healthcare.
Yes.
They have another third party.
Yes.
From a healthcare standpoint, all right, healthcare in general, around the world, right? Around the world, the government has done a great job managing healthcare in other countries around the world. Their respective governments have done a job that the people actually love. Most people love it,
I agree.
right? For some reason in America, we don't think that the government would do a great job, except, oh, hold on, the VA, they do just a fine job. Medicare, they do just a fine job. But for some strange reason, anybody under the age of 65 that's not a veteran, like, we don't think the government's going to do a great job. I have a hard time believing that that's the case, because every member of the government has somebody that's under the age of 65 that's going to need care in some way, shape, or form.
Yeah.
Now, there are going to be some difficult questions to answer, because there's a few different ways to look at this. You can look at this as, okay, well, how do we compare healthcare across the world? Okay, let's look at life expectancy, right? I think people live the longest in like Japan to like 82 or 83 years old.
Yeah.
But it's not just about life expectancy. It's not how many years you live. It's quality.
Yeah.
Or it's disability adjusted life years.
Yeah.
All of these things matter. And you do have to ask difficult questions. You do. Like, if there's a 95-year-old that lives in a nursing home that's had a bunch of strokes, that can't move, that's in the corner, that's on a ventilator because they're trached and they're getting, you know, tube feeds through a peg tube, and they're just in the corner of a nursing home, like, and nurses are taking care of them, and they're in this facility, that costs money. And you have to ask yourself, is this care appropriate? Is it providing a quality of life? I'm not going to sit here and answer that question and say,
yeah, we couldn't.
that person doesn't have quality, because, again, I've got elderly relatives too. Like, I understand that.
I hear your point, yeah.
But these are questions that other countries have answered.
Yeah.
Right? And these are things that we hear about probably in the news. I think in England it's called NICE, right? I think that's the name of the organization that makes these kinds of quality decisions. Like, is the care that we're going to pay for worth it for the person that's receiving it?
Is there a country that you have read about that you feel has a good model over others? Is there one you gravitated toward more?
You know, I think that the country that I gravitated towards probably the most would be like Germany, because they have private physicians and private insurers, sickness funds or whatever, funding healthcare, but the government kind of establishes how much it's going to cost. I gravitated towards that more, but I also understand that with that, you're still going to have differences in costs of certain therapies because standards of care can change. And then, we can't sit here. There's always competitive molecules or competitive surgeries, competitive, therapeutic strategies. So this is when I understand England, and they kind of go through the whole thing and they're like, okay, this is what we're going to offer. This is what you can get. Right. Period. End of story.
Right.
So
right.
I do like an element of choice, but I also understand that when it comes to healthcare, sometimes you're not going to have that so you can provide everybody with healthcare.
Bigger question.
Uh-oh.
Do you think with this Luigi situation that we're going to see any real change?
I don't think we're going to see any real change. I think we're going to see lots of discussion. I think we're going to see lots of opinions.
Yeah.
I don't think that we're going to see real change. And the reason is because you know how the news functions in this country. So there's a topic that's hot for a little bit.
Yeah.
Then it goes stale and it goes cold. And then that's the end of it. Until the insurance companies don't spend so much money on the lobby against the national healthcare system, you're not going to see a significant amount of change. I do think that the greatest amount of change we have seen in the last 10, 15 years has been the Affordable Health Care Act, or Obamacare.
Yeah.
Right? That people kind of take apart saying, oh, they shouldn't have to pay because they, can't afford it. Or the Affordable Care Act essentially says that everybody has to have health insurance and you got to pay a premium, and, you'll get some subsidized money, and certain people will get that. Either way, it did provide a significant portion of Americans with health insurance that they didn't otherwise have.
That they didn't have. Yeah, I agree with you.
Savannah.
Yes.
I'm going to ask you a question. Mm-hmm. You're a nurse.
Yep.
ICU nurse.
Yeah.
Holla. And you became a nurse practitioner.
Yeah.
Why did you become a practitioner now? And when patients get denied care that you're offering, you've promised, right? Technically speaking, writing the note and ordering the care. How does that make you feel?
Well, to start that, I went from being a nurse at bedside and I wanted to do more. I wanted to have more autonomy.
Yeah.
I wanted to have the opportunity to manage and treat patients. Mm-hmm. I wanted to be able to diagnose and provide a service to patients that was going to change their life, right? So now, being in the role that I am, working in clinic and having this opportunity to see patients, to say, okay, this is what's wrong with you and this is what we can do about it, which is such a privilege. And sometimes that looks like medication, sometimes that looks like a procedure. Mm-hmm. That brings me so much joy. But to the second part of your question, to then have insurance, who has, in my opinion, shouldn't have the say, right? Mm-hmm. To go against what I'm recommending and say no to this patient. No, we see that you want to give this patient this service or this medication that is going to save their life or improve their quality of life, but we say no. It breaks my heart. I mean, it really genuinely breaks my heart. And then to have to go to the patient who I just got excited with and was like, we're gonna change your life. And they're looking at me with respect and gratitude. Mm-hmm. And then I have to come back and say, well, I'm sorry, insurance said no. Right. And they still, and they're like, but why? Like they think that I'm the key there, right? And I can say, I said why you need it, why it's gonna be beneficial. Yeah. And they're still saying no. Right. And then, so then my next step there is, well, let me try again. Let me take these steps. And when it's repeated, no after no after no, this last week, another PA in my office came to me crying. It's gonna make me cry thinking about it. She goes, I want this patient to have this procedure so bad. She's been declined 3 times. And she's like, I don't know what else I can say. She read it to me.
What was the procedure?
She was having, She needed to have an angiogram for stents. She had history of coronary artery disease. She was horribly symptomatic. Same symptoms that she had previous. I think we had even done a stress test. The stress test was abnormal.
Like, it was read as abnormal?
Yeah, no,
That's
it was
crazy.
like, it was lined up. It was lined up. Like, there's no reason. And they would not do it. And she's like, what else do I need to say to these people? And the family is looking to her like, say it, do it, write it, whatever, you know? And 3 times, to the point where she was handing it off to other people, like, will you call them and see?
Yeah.
And we couldn't get it. We couldn't get it. It's crazy. And it's heartbreaking. And it's heartbreaking to see the family have to go through it. And you just feel like you go into this industry hoping that you're going to make such a big difference. And when someone who doesn't have any insight on how to manage these patients takes that away, it's really frustrating.
Here's the thing, you guys, is like when we do these peer-to-peer calls and we're on the phone with the insurance company's representative physician who has decided to say no to whatever you're asking for, 99 times out of 100, that person has no idea or any clue about what it is you're ordering and why. Mm-hmm. And you have to have a strategy of being able to deal with it. And I don't know what your strategy is, but I have a strategy that I try to execute when I do a peer-to-peer.
And I want to know what that is. I also just want to touch on the fact that we're at a point now where even sometimes that first peer-to-peer is AI, meaning there's literally just boxes. And if we don't know the boxes, but if somehow you didn't say the right thing or check their boxes, it's an instant no.
Yeah.
And then you're like, okay, well, that's ridiculous.
Right.
I'm not going to let some computer tell me that. Mm-hmm. And then you go for a real person. And to your point, oftentimes that real person, and these people aren't necessarily always rude. A lot of them are, but some of them are nice, but they're, but they don't even know your specialty. I'm saying these words. They have no idea what I'm talking about.
None. Yeah.
And they're looking for me to say keywords that, again, I don't know, but I'm throwing out every keyword that I possibly can, to the level where you're like, there's no way that you are not accepting this off of what I am saying to you. Like, you're begging for a specialist to be able to have the conversation with, because there's no one in their right mind who would say no.
Right. It just doesn't make sense.
It just doesn't make any sense.
Yeah. It's crazy. When I do a peer-to-peer, and I know you guys aren't necessarily thrilled when I get really detailed and I get really into the weeds about certain pathophysiologies. I get it. Part of the reason that I evolved to do that was because of peer-to-peers. So I get super technical and super detailed into pathophysiologic mechanism as I'm talking to the other physician. They have no clue. And because they have no clue and they don't want to feel stupid, they just say, okay, you can have it.
Yeah, you could say it either way. You could get into the weeds because you think maybe if I provide more, they're going to like understand. And you could say it as simple, point. And they're like, yeah, no. And you're like, okay, I can't win here. Yeah. I could be the smartest person in the room. I could say it in a way that any average person should be able to understand what I'm saying. And you're still going to say no to me. It's like it's a predetermined, they're just like, this third phone call is going to be a no. I feel that way sometimes.
Right. And the thing that makes this also really difficult is the fact that there's 15,000 different insurance companies, 15,000 different HMOs, 15,000 different PPOs, 15,000 different companies that you got to have these conversations with. Some companies are like, okay, cool, go ahead. Some companies are like, oh, hell no. And so you have to, there's nothing standardized in terms of how you get things approved. And I really feel that organization within that would be of significant help as well. Mm-hmm. Just even if you just had a standard across all of the insurance companies in this country, said this is the standard, period. This is what you can do. This is the eosinophil count you have to have. This is how many episodes of paroxysmal atrial fibrillation you have to have before we're going to approve this procedure.
Right.
Period, across the board for all the companies.
Yeah.
You at some point you have to grab everybody up and you gotta reorganize things, right? At some point you have to do that. It's like your kids. Like when my kids were young and we had a big basket, right, full of like stuffed animals and toys. All right. They would come to the living room in the morning and they would take every single toy out of there.
I'm familiar.
Right? You're familiar, right? You're probably going through right now. And every single toy is just spread out like all over the floor.
Yeah.
And it's completely disorganized and it's awful. And then you come in the room and you're like, you know what? I need to grab up all the shit, put it in here, and let's organize this right. Let's get this done correctly. All right, let's take all the balls and put it in this basket. Let's take all the stuffed animals, put it in this basket. Let's take all the Legos, put it in this basket. So you just got to reorganize these things. And I feel like with healthcare, you just have to reorganize it. And unfortunately, on that reorganizing of it all, hopefully we could take money away from these insurance companies, which are paying dividends to their investors, which is just nuts.
Yes.
They're making billions of dollars, and put it back in to providing care for all the individuals who don't have health insurance, right?
Yes.
And making sure that physicians are compensated appropriately. Not spending 50% of their day or having to hire more staff to, I don't want to say fight the insurance company, but that's what's happening.
I mean, yeah.
You know, to discuss with the insurance company why certain things are necessary. Mm-hmm. I mean, I don't know about you, but a lot of times I'll just send the patient to the hospital. And I'll be like, go on to the hospital. I'll do it there.
Yeah.
I'll get you admitted. I'll just get it done as an inpatient. That's fine.
We do what we have to do as providers to take care of our patients.
We do what we have to do to take care of our patients, for sure.
So we've touched on a lot of subjects, but one I think we really need to hone in on is those that are underserved, those who don't have access. How are we, or what are we doing for them?
You know, I spend a lot of time educating in this space, and I've got a lot of friends, a lot of other faculty members that spend a lot of time developing curriculum in the space of the underserved communities. And so when you look at the underserved communities, which are individuals that look like me or individuals who are farmers, right? They're underserved. They don't have the access that the average individual has. But then I think about the entire country as a whole. And when you look at the entire country, when you look at the United States as a whole, there's a significant portion of people who don't have access. So there's a lot more than just the underserved communities. Yes, I want to educate people that look like me. I want them to understand what it is and what it means to have diabetes, what needs to be done from an hypertension standpoint, what needs to be done from an asthma standpoint. But even more than that, I want to make certain that the country has a plan for individuals to actually be able to participate in healthcare. Yeah. I don't want people to be left out. I don't want people to go by the wayside. I don't want people dying of completely treatable and curable disease as a result of lack of insurance.
Yeah, I agree.
That's not something that one of the richest countries or the richest country in the world should be associated with.
I agree.
And I think that's where the world really gets upset at the United States, is in that manner. And this, I understand 100%.
So usually we like to end our episode with what we call a positive pulse, where we highlight a positive story related to what we discussed that day. Today's topic was very vulnerable. It's a very heavy topic. So instead of doing a positive pulse the way that we usually would, we're going to do it a little bit differently. Jamie, I think we want to start off by showing gratitude to our coworkers, to the providers who are really going out of their way to push the boundaries and help their patients, especially when it comes to healthcare.
No, Savannah, I think that's great. I completely agree with you. We do want to express gratitude to all the physicians that are out there fighting for their patients. Again, all the effort that all of you are putting in to make certain that your patients get their treatments, it's appreciated, and we just want to say thank you.